Okay, great. So hi everyone. We'll start with the operatives for undergrads. It's going to be a 2-hour session, and we'll be discussing a few of the operative procedures which are important for you to, I would say, not pass your final professionals, but build an understanding about surgery and how do we operate. So hi, I'm Dr. Ayush Badani. I'm an MBBS pass out from Magical Medical College and Hospital, Kolkata. A proud Centurion batch from there. I'm currently a surgery resident at AIIMS PATNA, and I'll be covering for you the operative procedures in surgery, and it'll be a guide for the undergrads students. So before we go ahead, Ramanut sir, Guru Brahma, Guru Vishnu, I've learned everything from him, and he's my source of inspiration. I've seen him teach to me, to so many other people. I've learned operatives from him. It's just a small effort from my end uh, to just go ahead with it. So great. So these two pictures. Okay. So these two pictures which we see here, this one is of Shashrut, and this is when we surgeons were called as glorified barbers. So why I want to tell you this right now is we surgeons are nothing but glorified barbers, and we just know how to cut in the right way to give it a nice, beautiful shape. Right? Shushut, the father of surgery. And before we go ahead, we'll just like to discuss the list of contents. We'll be starting with the basics, that is the sutures, blades, and incisions. Then we'll go ahead with hernias, Lichtenstein Hernioplasty, Ram's patch, lap open coli, lap open appendix, MRM, thyroidectomy, and few minor procedures, that is venesection, eversion of sac, and circumcision. So I hope everything is all good till now. So we'll be starting with sutures, blades, and incisions. So why is this important? See, surgery is nothing but restoring back the anatomy. So there is a pathology inside your body. To access that pathology, we need to open up whatever is there above it. As simple as that. So you have a parotid to excise, you have to open the parotid. You have a gallbladder to excise, you have to open the abdomen, get to the gallbladder, open it. You have a hernia to operate, you have to incise the muscles, go in, operate the hernia, switch it back. So how do we open it up? Is what comes as blades. So we have basically 5 main blades. We have 10, 22, and 23, which are the main skin incisions or the larger skin incisions blade. We have the 15 number blade for smaller incisions, something like a thyroidectomy, something like a parotidectomy. We have the 12 number blade, which is a curve. So obviously we understand that if it's curved, we can hook it to some structure and cut it. So for example, there's a drain and it has been fixed with sutures. So you can just hook it and cut it. Also some threads, right? Then we have this infamous 11 number blade or the stab knife, which we use for incisions and drainage. So this is the suture blades, and these are the Langer lines. So these are the lines of orientation of the dermal collagen. So the basic idea is, if we cut along these lines, the post-operative outcome of the patient will be better, will be aesthetically good, and also because of the direction of the collagen fibers, it will heal better. So we as surgeons are nothing, but we just approximate things. We say it is the God who heals. If not the God, it is you and your own body which heals. So what is our duty as surgeons? To open it up in the right direction, operate on the pathology, take it out, switch it, stitch it back, right? So going ahead with the sutures. So I've tried to summarize this table a little different from how you guys usually root sutures. I've not summarized it at absorbable, non-absorbable, and stuff. I'm expecting you know a little bit about it. What I've tried to do here is to understand as to which suture can be used at which place to suture it. For example, you have a skin which is incised and you need to suture back the skin. So what do we use? We use something as simple as nylon. It is a monofilament synthetic thread, has excellent properties, and the common name is ethylon or the daphylon, and the raw material being polyamide. Then we have to secure drains. As I said, To remove the drain, we use a 12-member blade. But to secure it, we need a suture which is outside the body. So we'll prefer a suture which is a little, even if it's not inert, it's fine. So that is silk. We have polypropylene or the proline. And proline is used mostly for vascular anastomosis. When we do a hernia repair, we'll suture the mesh to the underlying tissue. We'll be using proline there. For bowel anastomosis, first and fourth layer. And then we have the vicryl. So I'll tell you something. Vicryl is known as the workhorse. Why? Vicryl is an absorbable suture which has excellent properties. It is a polymer of lactide and glycolide, and it can be used extensively for gut anastomosis, subcutaneous closures, vascular ligatures. Then we have something as the fascia, that is the rectus or the external oblique. We need to close that fascia. What we'll be using is, just mute everyone just a second. Okay. So what we'll be using there is something known as PDS or polydioxanone. It is a polyester suture, an excellent synthetic but absorbable. That is very important to note. Then we have something like a monocryl for subcuticular suturing. So I hope it's clear for now. We'll come back to this slide as we go and discuss other operatives. So before we go ahead, we need to understand some basic incisions. This I had shared on your WhatsApp group. So what we need to understand are the various incisions. I'll just come this side. We have number A or the sternotomy, which we use for CABGs or the heart procedures. We have B or the periareolar. Periareolar incisions are used for fibroadenoma. We have C or inframammary, again for a mass or a fibroadenoma which is located in the inferior quadrant. We have D or the coccus, right? We go ahead with the open cholecystectomy. E is a little paramedian. Which is the median one is the M, median or the vertical laparotomy incision. L is the chevron top. This is infamous for the operation known as Whipple's, where we have to operate at a larger extent, operate on the liver, gallbladder, pancreas, and everything around. We have N or the inguinal incision, which we'll be using for inguinal surgeries. And we have H or the McBurney's incision for appendectomy. So this is a summarization of all the incisions where we can use. We'll just quickly revise. We have chevron for Whipple's, right subcostal or the coccus for cholecystectomies, CBDs. We have the midline for all sorts of exploratory laparotomies, right paramedian for gallbladders, right hemi. Forget that. We have the McBurney's, inguinal, Penestile or the ones which is used for cesareans, right? We have the lower midline, again, when we want to approach the urinary bladder and the uterus and all around it for the urogynecological procedures, and the midline. So these are the basic incisions which we'll be using. If everything is fine till now, I just request a small thumbs up from your end, right? So now, what we need to understand here is, for any operation to be performed, we need to cut, right? That's very simple. But cut what? Again, whatever is there above the pathology or whatever is needed to cut to reach that pathology. So in order to know what to cut, we need to understand as to what is the abdominal wall anatomy. We have been reading it from our first year, right? That above the arcuate line, we have a rectus abdominis, which is formed. And below also we have, but above the arcuate line, we have the external oblique, internal oblique, and the transversus abdominis, where the external and internal form the anterior rectus sheath, internal and transverse form the posterior rectus sheath. But below the arcuate line, the posterior rectus sheath is not there. It is only the anterior rectus sheath which is there, which is formed by all the three muscles. Coming to this entire anatomy, I request everyone's attention for some time over here. So this is the linea alba or the midline. We have the rectus sheath. Obviously, this is the anterior rectus sheath. We have the rectus abdominis. We lift the rectus abdominis. We have a posterior rectus sheath. We have a linea semilunaris, which is the lateral border of the rectus abdominis. Forward. We have three important muscles. Understand, external oblique, internal oblique, transversus abdominis. So no matter what operations we are going to learn, we'll be either incising in the midline or the linea alba for laparotomies. For a coccus, we'll be incising the rectus abdominis. Over here, some part of the external oblique, maybe some part of the internal oblique. For hernias, we'll be incising the external oblique, then we'll come down inside the internal oblique, then the fascia transversalis. For all the OTs which we are going to learn today, this is the basis. So I hope everyone is clear till now. So we'll be starting with our first OT, that is the Lichtenstein Hernioplasty. What we'll be doing is we'll be discussing each operative under 5-6 main headings. The first one is the indications. Second is anesthesia. If there is a pre-op preparation required, I'll discuss it. The positioning, then we come the antiseptic dressing and draping, the steps, the complications, and its management. I hope it's all clear. Indications, anesthesia, position, steps, complications, management. So if you understand any OT under these 5-6 headings and just tell whoever is the examiner under these headings, I'm sure you will be easily able to pass the exam. And anyways, we're not here to pass, but to learn a bit of surgery. So we need to understand that Lichtenstein hernioplasty, the indication being an inguinal hernia, both direct and indirect. Anesthesia, usually we go for a spinal. We can even do a local. And for elderly, we can go for a GA. Obviously, if the patient is not able to tolerate the spinal due to hypertension or other reasons. So I like you to understand this particular anatomy. Okay. So we have the rectus abdominis, we have the external oblique, internal oblique, transversus abdominis, and the transversalis fascia. Okay. So as we know, we have an inferior epigastric artery and vein. The hernias which are lateral to it are the indirect inguinal hernias. The hernias which are medial to it are the direct inguinal hernias. So what is a direct inguinal hernia? It is a weak area in this transversalis fascia, whereas an indirect hernia comes through the deep inguinal ring, travels all the way through the spermatic cord and reaches the scrotum. Just try to understand here that the external oblique fascia forms the external spermatic fascia. The internal oblique fascia forms the cremasteric muscle and fascia, and the transversus abdominis fascia or the transversalis fascia forms the internal spermatic fascia. We'll have to remember this point once we come to eversion of Sac or the hydrocele. Just another point over here. What are the structures in this spermatic cord? We have 3 fascias, external, internal, and the cremasteric. 3 arteries, testicular, cremasteric, and the artery to the vas deferens. 3 veins, again the testicular vein, cremasteric vein, vas deferens vein, which forms the papilliform plexus. And 3 important structures. In males, it's vas deferens. In females, it's round ligament. 3 important nerves, the inguinal, genital branch of genitofemoral, and few sympathetic nerves. I would like you to remember this rule of 3 for spermatic cord contents because it even comes for your final exam theory. Great. So starting with the steps of Lichtenstein hernioplasty. So we have a hernia. We need to open it up, get to the hernia, open the sac, reduce the content, sew the sac back, put a mesh, and close. As simple as that. Let's come to the steps. First will be the marking of the incision. We have the anterior superior iliac spine and the pubic tubercle. When we join this is nothing but more or less the line of the inguinal ligament. Just 2 fingers above it, medially, we make an incision. Once we go in, we have something known as the external oblique, right? That was the first muscle. So we'll be incising the external oblique along the line of the incision. Great. I'll just mute. Okay. Great. So this is the external oblique fascia. We have incised it. The moment we incise it, we'll be entering into the spermatic cord or the inguinal canal. I'm sorry, we'll be entering into the inguinal canal. We have the spermatic cord over here. We have the ilioinguinal nerve. And what we see here is a direct hernial sac, right? So before we do anything further, we need to separate this sac properly from this entire cord. Once we are able to do it, we open the sac, reduce the content, sew it back, and then we'll also form a new internal ring and we'll go on putting a mesh. That is, we'll put an inguinal incision medial to the pubic tubercle, extending laterally beyond the deep inguinal ring 2 centimeter above and parallel to the inguinal ligament. Done. We'll first incise so we'll be incising two subcutaneous tissue, the campus and then the scarpus, C, then S. Coagulate 3 important vessels, superficial epigastric, external pudendal and circumflex ilia. Expose the inguinal canal. As soon as we cut the external oblique, we have access to the inguinal canal. We dissect, we basically open the fascia, then dissect above, dissect below, and pull up flaps. So this is dissection of the upper and lower flap. The moment we do it, we expose the conjoined tendon, that is the joining of the internal oblique and the transverses. Then we dissect the hernial sac. It's very important over here to dissect it carefully from the spermatic cord, identify the sac characteristics, make sure not to damage the nerves and vessels. I told you which are the nerves and vessels. Then open the sac, reduce the content, and put it back in the peritoneal cavity. What we have next? If we have an indirect inguinal hernia, so this is the sac. We need to open it up and put a purse string suture around it. Cut the excess sac, put a purse string suture around it. That is nothing but a herniotomy. That is twisting of the hernial sac and then transfixing it. Once we are done with it, we need to put a mesh. That is how the name comes to be Lichtenstein Hernioplasty or mesh hernioplasty. What is this mesh? So this mesh is nothing but a polypropylene mesh. It's extremely strong. We have a 15 into 7.5 centimeter mesh and we refashion it. We cut it, we make a small opening over here. Why? Because we need to put that spermatic cord through this. Then we fix this entire mesh over the conjoined tendon, over the inguinal ligament, the pubic tubercle, and make sure to reconstruct a deep inguinal ring. Why? Because if we do not reconstruct the deep inguinal ring, we'll have a chance of recurrence. So this would be the final picture where we have a mesh placed properly. And what we need to do next is just stitch back the external oblique. Okay, just a second. Yeah. So we need to stitch back the external oblique aponeurosis, stitch back this subcutaneous tissue and the skin. Again, the question, how do we stitch back the fascia? Either with a PDS or ideally with a vicryl. How do we stitch back the subcutaneous tissue? With a vicryl. We talked about it. How do we stitch back the skin? Either with a nylon or a subcuticular monocryl or staplers. So this is all about a Lichtenstein tension-free mesh hernioplasty. This video I just played. So what you see here is that I've dissected the external oblique. This is the direct sac. This is the spermatic cord. You see how I can push the direct sac inside because there's a defect. And I'm just trying to demonstrate the pre-peritoneal fat, which marks the deep inguinal ring. And this is the entire picture. So once we are done with it, what we'll be doing is we put a mesh and we suture it to all the ends. All right. So we have sutured it to all the ends. As simple as that. So what are the complications? SSIs, hematomas and seromas, and mesh related. So mesh related, we need to understand that if there's a mesh, the SSI definition changes to 1 year. For hematoma and seroma, we need to just observe for any evidence of bleeding or hematoma. And if there's a SSI, we need to give the antibiotics. So this completes our first operative. I hope this was clear. So we are going ahead with herniotomy. Remember the step we did, herniotomy, where we basically pulled up the sac in indirect inguinal hernia. We cut the sac, twisted it, put a transfix suture, put it back, close. This is nothing but herniotomy. Where? So this is what we do in pediatric patients. Why? So, छोटे बच्चों में external oblique, internal oblique, transversus abdominis, all these muscles are not well developed. Second, cannot afford to put a mesh. Come on, right? The baby is growing. It will be a blunder. It will be a crime to put a mesh. So what do? We simply go in. Okay, this is the pathology. I see a sac. Open the sac, reduce the content, cut the excess sac, transfix it, put it back, close. That's it. Great. So we put an incision, usually, which is parallel to a transverse skin incision over the groin. Usually it is along the groin crease, where at just the deep inguinal ring, we incise the external oblique aponeurosis, go in, we see a sac. isolate and dissect the cord from the sac, gently tease the covering of the sac so that if at all there is the internal spermatic, external spermatic, or the cremasteric, we just remove all those muscles, save it, save the vessels, save the nerves, open the sac, reduce the content, transect the sac. So whatever is distal to the sac, which is going to the scrotum, we just cut it and leave. Why? Because if we suture it back, there might be chances of bleeding and formation of a swelling. So we just leave it so that if there's small amount of bleeding, it will get absorbed. But what we do with the neck of the sac is we hold the proximal stump with two hemostatic forceps, pull it up, transfix it with a suture, put it back. What kind of suture? We cannot afford over here a proline because it's a small little baby. So we usually do it with a vicryl. Then we close the external oblique aponeurosis with vicryl and the skin with subcutaneous sutures. As simple as that. Again, we cannot afford to put a nylon on the baby's skin. It's very gentle. We need to put a subcuticular suture, just approximate, and babies heal beautifully well. By the way, I'm right now in pediatric surgery, so I know a little bit. So I think we're done with the inguinal anatomy and the two important operations there, that is the Lichtenstein and the Herniotomy. Before we go any further, we need to understand how we enter the abdomen. So once you enter your surgery residency, doing a laparotomy independently is the most happening thing you can imagine. And it's a beautiful feeling, I must tell you. So what you need to do again is we glorified barbers, glorified surgeons, go in the midline, put an incision from the xiphoid to the pubis symphysis. This is the long incision. You can do it a smaller incision or like above or below, depending on where the suspected pathology is. See this, right? So we incise the skin, then two assistant, the surgeon and the assistant will pull the subcutaneous tissue apart. Over here, we use cautery. We keep on incising till we reach the linea alba fascia, right? Linea alba is nothing but condensation of the anterior rectus sheath in the midline, right? So once we open it up, we see something known as a peritoneum popping just below it. Now you need to understand one thing here. Just below the peritoneum is the bowel waiting to say hi. The moment you go in, enjoy the bowel, we're kicked out of DOT. As simple as that. We don't want to do that. What do? We put the peritoneum, pull it up, so this pulling it up would be done by the assistant as well as the surgeon. Then take a nice fine scissors, put a small nick on the peritoneum, and under vision, dissect it up, dissect it below with the finger beneath. This is what I'm trying to explain. Why? Because we need to safeguard the bowel which is below, right? So we incise, make a midline incision, we do the linea alba incision, we lift and incise the peritoneum between forceps, avoiding bowel adhesions, then divide the peritoneum with scissors along the incision, taking care around the falciform and lower end to avoid bladder injury. You don't want to injure the bladder. Then we close. How do we close? So I told you, for closing the linea alba and the fascia, we need something known as PDS, polydiapsonone. The latest literature says, if you refer to Bailey, the best suture over here to use would be a 20 PDS. I'm expecting you know about 10, 20, 12. If you don't, I'll cover it in another class, but not here. So we use 20 PDS, or what we usually use is a loop PDS, and stitch it continuously or in an interrupted fashion, depending on the elective or the emergency laparotomy, and then close the skin with interrupted monofilament polyamide, that is nylon or staplers. So this is the midline laparotomy. So now you have a patient coming in the emergency, not eating like us MBBS and surgeons and UG fellows for days, not having breakfast, and all of a sudden developing a severe epigastric pain. There is tenderness, rigidity. The intern on duty goes for an X-ray, does an X-ray, and what you see there is gas under diaphragm. What's the diagnosis? So before we go ahead, can you guys give me some differentials of gas under diaphragm? It's a very important question for you all. Answers? Perforation, okay, peritonitis. See, peritonitis is not a diagnosis per se, okay? It's a clinical diagnosis. A patient can be in peritonitis following perforation of anything, right? Hollow viscous perforation, subdiaphragmatic abscess. Okay, so basic chiladity, great. I was waiting for that answer. You know, I'll tell you a small incident which happened. So post a lap cholecystectomy, patient was having some chest pain, and we got an X-ray done. The intern on duty, just starting with surgery internship, came running to me saying, boss, in Patna, they call us boss. And he says, boss, the patient has got a perforation. I said, what? Perforation? How? He said, boss, there is gas under diaphragm. And then I had to tell him that, bro, that gas under diaphragm is nothing but due to the pneumoperitoneum which we created. So don't get confused over there. Just a small little example. So we have a patient coming in with a hollow viscous perforation, as you all said. We have two DDs, either a peptic perforation or a duodenal perforation at your level. We'll not be considering the ileal perforations and stuff. So we have something known as a peptic ulcer perforation. We have a small perforation in the stomach or in the D1, D2 junction. How do we approach it? Very simple. We have to open the abdomen via an upper midline incision. But before we do this, here is where comes the importance of pre-operative preparation. Why? See, we as surgeons are doing a surgery not to kill the patient, right? If the patient is not able to tolerate the OT itself, there's no point in doing the OT. So if the patient is extremely sick, the patient requires vasopressor support, we need to resuscitate. So what there comes the important principles of A, B, C, D, especially the C. We need to give intravenous fluids, vasopressors if needed, blood if needed, whatever is needed, you need to give it. Then plan the patient for OT, put it under GA, supine position, do a midline laparotomy. The moment you'll open it, you'll see a gush of fluid coming in. Extremely feculent if it's an ileal perforation. But if it's a gastric or a duodenal perforation, it will be mostly be bile stained. You'll be fine. There'll be a lot of pus flakes. So that is what you'll see is there'll be escape of gas and bile stained fluid. Remember to send up fluid culture and sensitivity here, because you need to understand as to which is the bacteria causing the sepsis so that we can start the right antibiotic for the patient. So then we'll localize the perforation site. We'll retract the liver with a devers if needed. We'll inspect the distal stomach, the duodenum. If needed, open the lesser sac, go on the back side of the stomach, etc. But what we basically need to do is, once we identify the perforation, we need to close it. For closure, we need an absorbable suture. And the best suture, which is an absorbable, the workhorse, is nothing but, correct, a vicryl. So we put a simple 3 to 4 interrupted polygalactin, nothing but vicryl sutures, with central suture passing through the center of the perforation. So if this is the perforation, we need to stitch like 1, 2, 3, 4, so that at least the central suture passes through the center of the perforation. Then we sew it, right? Simple. But that's not done because we need to modify. That is when modified Graham's patch repair came in. So what is the patch? We have the policeman of the abdomen or the omentum. Beautiful thing. Just put it up take the omentum, put on the perforation, and with the same sutures, tie the omentum. As simple as that. Then, once you're done with it, obviously you need to do a thorough toileting. Put in lots of warm saline, wash the entire abdomen, make sure there's no collection in the hepatorenal, make sure there's no collection in the Morrison's. If needed, put a drain, which we usually do. If there's a huge perforation in the stomach, we might even do a feeding jejunostomy because we don't want the patient to starve, right, and die. So post-operatively, you have to maintain a continuous orogastric aspiration with a Ryle's tube. Again, Ryle's tube, a very important question, okay? You need to give intravenous fluids. We need to give the right set of antibiotics, something like Amica, third generation cephalosporins. Very important, if the patient is having a peptic perforation in the gastric, right? You need to send a biopsy. Can someone answer me why? Why do you need to send a biopsy in case of a gastric perforation? I'll wait for the answer. Then we have to basically initiate the oral fluids later. I'll just show these pictures again from Zollinger. Okay, this is our Bible. So this is the duodenal ulceration. This is the perforation. 3 stitches, close it, put the abdomen, suture it back. Next, pre-pyloric perforation. This is the ulcer. You take a biopsy, pass 4 sutures at max, not more than that. Close, put the omentum, stitch it back. As simple as that. H. pylori. No, Rahul. The reason why we send a biopsy is because most of the times these perforations can be due to gastric cancers, right? And also in a long-standing ulcer, there's a high chances of development of gastric cancer. So if there's an ulcer which has bled, we need to send a biopsy from across the edges so that if it all there is a malignancy, it can be diagnosed. So the next question is, which is the most common artery which bleeds in a duodenal perforation? Let's see if I have that answer from all of you. Okay, so I think we are done with the midline laparotomy. We need to shift a little up, the infamous cholecystectomy. Do I have an answer? Okay, right, gastroduodenal artery is the right answer there. Good. So cholecystectomy हमारा bread and butter. जब तक गॉल ब्लैडर में स्टोन है तब तक हम सर्जन्स के पास जीने का एक रीजन है. So what we do mostly at AIIMS is the laparoscopic cholecystectomy. Very rarely we do a open cholecystectomy. But you need to understand few important aspects. Number one is the indications. And number two is this famous triangle, the Calix triangle or the hepatocystic triangle. First, the indications. Chronic calculous cholecystitis, acute cholecystitis, mucocele, empyema, porcelain gallbladder, carcinoma, adenomatous polyps, that is polyps more than 10 mm, traumatic ruptures, and along with Whipple's, right? So these are the indications. We can learn it later, but what we need to focus is on this beautiful anatomy. We have the liver, we have the gallbladder, we have the common bile duct being joined by the cystic duct. We have the common hepatic duct. So we have the common hepatic duct and cystic duct forming the common bile duct. We have the left hepatic artery, the right hepatic artery, and the hepatic artery proper. So the latest Bailey says that Calix triangle is also known as the hepatocystic triangle. So earlier, we used to have two separate triangles, a Calix triangle and a hepatocystic triangle. But what you need to learn right now only is that Calix triangle is same as hepatocystic triangle, where the borders are superiorly the inferior surface of the liver, laterally is the cystic duct, and the medial border of the gallbladder, and medially is the common hepatic duct. So as I said, we know nothing but cutting, suturing it back. So we have a pathology in the gallbladder. Before we take out the gallbladder, we need to cut two important structures. Number one is the cystic duct. Why? Because if we don't cut and ligate the cystic duct, whatever bile is coming from the common hepatic duct will keep leaking out from the cystic duct. And you don't want bile in the abdomen. We need to ligate the cystic artery, cut and ligate. Why? Because if you don't, it will bleed like anything. Okay, that is one of the most major complications of a cholecystectomy, a bleed or a cystic artery blowout. Like after tying the cystic artery, if it keeps on bleeding. So just forget whatever is written over here. I know it's a lot of content. We focus over here. We first start from lap cholecystectomy. Okay, so this diagram, right? So we have the patient sleeping. We have the surgeon on the left-hand side. We have a second assistant who will show the camera. We have a first assistant who will retract the gallbladder, which we'll be doing as interns. And then we need to go inside the abdomen. How? For going inside the abdomen, we need to create something known as the pneumoperitoneum. Pneumo, air, peritoneum, inside the peritoneum. Do we insert air? Do we insert helium? No. We insert something known as carbon dioxide. As simple as that. So we put an incision just below the umbilicus, small incision. We use a Veres needle. It's one of the very important instruments. This Veres needle, which you must have studied from Rohan sir as well in the Marrow videos or whoever coaching you take, you need to put in the Veres, enter the abdomen, put the CO2 in. Sorry, before checking you are in, for the abdomen, you need to put some saline, then put the CO2. Once you understand, okay, the pressure inside the abdomen is decent enough, then you go in with your trocars. First trocar in the umbilicus. Once you enter the trocar in the umbilicus, then the assistant, the camera guy, takes the camera inside. Again, we are no great people. We are just surgeons who need to operate the pathology. To know and to see the pathology, we need a nice high definition camera. So the assistant goes in with a camera. He shows us the view of the liver, the gallbladder, and the entire hepatocystic triangle and everything around. And then the surgeon gets in, inserts an epigastric port to a mid-clavicular port, a mid-axillary port, and then puts some instruments inside. We operate on the gallbladder, take it out. Let's see the steps. So this is the patient positioning and the surgeons around. Over here, we have tried to insufflate the CO2. After insufflating, we'll put the fiber optic light or the camera, basically. Then we put another port in the epigastric, just a little lateral to the falciform. Get in, visualize the gallbladder. Put two other ports, held the gallbladder, whoever is the assistant, he'll hold the gallbladder, pull it up towards the opposite shoulder, and then we'll try to dissect whatever is there in this part of the hepatocystic triangle. Why? Because it's not so easy. You have a lot of mental adhesions, especially if the patient has had an episode of acute cholecystectomy. There might be bowel adhered to it. There might be some other structures. So you need to be carefully dissecting them out so that you can perfectly achieve the right Callet's triangle and the critical view of safety, where two and only two structures should enter the gallbladder. That is the cystic duct and the cystic artery. Once you have exposed the cystic duct and the cystic artery, you need to go in with a clip applier, apply clips on the cystic artery. 1, 2, 3, 2 proximally, 1 distally. Cut. Again, put 3 clips on the cystic duct, 2 proximally, 1 distally. Cut. You have the gallbladder now separated from the cystic duct and cystic artery. All you need to do is remove this gallbladder from the gallbladder bed or the gallbladder plate. We'll just go back and revise the steps. So patient will be under GA. We'll have an antiseptic cleaning from mid-chest to mid-thigh. Whatever laparotomies you do usually start from the mid-chest up to the mid-thigh. Why? Again, because there's a high risk of conversion to an open cholecystectomy. So you need to understand what incisions you're going to give. Right. Initially, the patient is supine, but after you have put in all the ports, is then when you put the patient on a reverse Treadlenberg with right side up. You establish the pneumoperitoneum. A 1 centimeter smiling incision is made below the umbilicus. Veris needle is inserted. Carbon dioxide insufflation begins. Then the first 10 mm trocar blindly below the umbilicus. Then a 30-degree 10 mm telescope. Forget it. Just remember there's a telescope attached to video camera inserted through the infraumbilical port. Then two additional ports are put. One 10 mm at the epigastrium, one 5 mm at the right mid-clavicular, and one 5 mm at the right anterior axillary. So these will be the port positions: umbilicus, epigastric, so we have a right mid-clavicular and a right anterior axillary at the level of umbilicus. This umbilicus port is the one through which the camera enters. This epigastric port and this mid-clavicular port are the two main ports of operation. And we have a second port, that is the right anterior axillary port, through which the assistant retracts the gallbladder up. So once you have done that, you need to dissect the cystic pedicle and the Callet's triangle. We have the patient position in the reverse Treadlenberg and further. Next steps. Okay, right. So we need to apply the clips and divide the cystic duct and artery. So we have titanium clips. We need to dissect the gallbladder from the liver bed. Again, after doing everything, there might be some bile spillage, some small bleeding. So we need to irrigate and suction it out, then extract the gallbladder, usually, or I would say mostly, we take it out from the epigastric port. It's a good habit to put the gallbladder in an endolumen bag. It's just like a plastic bag, or you can use the gloves for the same. Put the gallbladder inside, take it out. Place a drain if need be. So suppose I have to do a lap chole, and these are one of the first 2 lap choles I'm doing. So I'll not be very confident. I might injure some small vessel. I might be skeptical, if there is cystic artery blowout, how will I know? So in that case, I might end up putting a drain and take it out through one of the ports. It's a habit which you can do, you cannot do. It can be omitted. And then you close the incision. Very important to understand here is that we have the fascia which we have opened very deep. So to close it, again, we need to use an absorbable suture. In this case, it's a port closer bicryl. Just remember this point. And we only close the 10 mm ports. Why? Because these 10 mm ports can turn out to be the locations for future hernia, right? You don't want a hernia at the site where you have operated, because then possibly our patient would sue us. You don't want that, right? At least I don't want it. So the important question is, why are we discussing lap chole first? Why is this? Why is there a reason why we are doing so much of lap choles and we have almost abandoned open chole? Because lap chole has now become the gold standard. It gives a highly magnified picture of the whole hepatocystic. You can visualize the arteries. You have immunofluorescence and angio, which is coming in. So it provides better cosmetic belief. I'm sure most of you would not want a open Cocker's incision over here, subcostal incision. So it enables early return to work. We usually discharge our patients on the same day or next day. And now lap chole is more or less turning out to be a daycare procedure. What is important for you to understand is that for any lap choles we operate, we make sure to take a consent for open cholecystectomy, because we don't really know as to how the anatomy is going to be once we enter the abdomen. There might be extensive adhesions. The cystic artery duct might not be able to delineate it properly. So over there, we need to go ahead with something known as the open cholecystectomy. Again, very simple. Let us revise back to the anatomy of the anterior abdominal wall. Over here, we had the rectus abdominis, external oblique, internal oblique. Beneath that, transversus abdominis. Over here also, we have something known as the external oblique, then we have the internal oblique, and we have the transversus abdominis. But we have something known as the rectus abdominis in a huge bulk, just where we are going to give an incision. So it's very simple. You need to plan the incision, give the incision, this or cut the rectus abdominis, then cut the external oblique, internal oblique, visualize the gallbladder. If there is any peritoneum or if there is any omentum adhered, you need to dissect it off, put some retractors so that you can pull up the gallbladder, pull up the liver. I'm sure many of you as undergrads must have attended and done this before. Then again, the same funda, see the cystic duct, cystic artery, ligate it, in this time not with titanium clips, but possibly with sutures. It can be silk, it can be vicryl, ideally vicryl. Again, take out the gallbladder from the liver bed using a cautery and close all the layers as you open them. So first you'll be closing the peritoneum, then you'll be closing the external oblique, in the rectus abdominis, and then the subcutaneous tissue and the skin. That's what we are going to learn. So why I've highlighted this Cocker's subcostal incision is because this is a short question which you might be asked when you are when you get that open chole card, that describe the Cocker's subcostal incision. So it begins in the midline below the xiphoid process. Okay, we'll understand. It begins below the midline at the xiphoid. Great. Extends downwards and laterally. Okay, I'm going downwards and laterally. 2.5 centimeter below and parallel to the right costal margin. Cool. So we have the right costal margin, 2 centimeters below the xiphoid, move downwards and laterally, approximately 15 centimeters in length. Nowadays, people are doing at 10 centimeters, even smaller, but for your level, understand the 15 centimeter. Okay, fine. What do I cut next? Anterior rectus sheath, great. External oblique, great. Why? You understand? Anterior rectus sheath would be at just this part. But once we go laterally, we'll encounter the external oblique. So we'll cut the anterior rectus sheath, then the external oblique. The moment we cut the anterior rectus sheath, what we'll see is rectus abdominis, correct? So we'll divide the rectus abdominis. Once you have cut the external oblique, what we'll see is, correct, internal oblique. So we'll cut the rectus abdominis and the internal oblique. Tada, where are we? Posterior rectus sheath. Cut the posterior rectus sheath. Next, peritoneum. Cut the peritoneum. And we enter into the abdomen. Once you are in the abdomen, examine the stomach, the duodenum, colon, pancreas, liver. Examine the gallbladder for any adhesions, for calculi. Examine the common bile duct. There should not be any stones, ideally, if you have done a proper pre-op ultrasound. Then you place some mops and retract So when you check ML Saha, there are 3 places where they have asked you to keep the mock. I'll not ask you to remember it because there's a very short time for your MV. So just remember, you put some mock, retract the liver, and you go for the dissection of the cystic pedicle. Identify the cystic duct and artery. Great, I've identified it. Next, ligate. Okay, I ligated them. Then we'll cut it. Great. Then we dissect the gallbladder from the liver. Over here, we have something known as the Moynihan's forceps. You must have seen in the OTs. If not, if I take an instrument class by any chance, I'll show the Moynihan's forceps over there. Then we divide the fringes, whichever is there, the peritoneal reflection, put it up, take it out. Obviously, it's open, so just take it out. Make sure there's adequate hemostasis. If there is not, you put some coagulation, put some ligations, maybe some sutures. Again, put a drainage tube or a drain if you want, if you don't want, and close the layers. Again, how are we going to close the layers? Peritoneum, biquill. So what was the next structure we cut? Posterior rectus sheath, again fine, we'll do a biquill. Internal oblique, fine, biquill. Then was rectus abdominis, external oblique, biquill again. Anterior rectus sheath, biquill, great. So we don't really do it like individual layers, but if possible, it's great. Some people are in a rush and just do a sort of suturing of en bloc. It's up to you and the institute preference. And then you have the subcutaneous tissue, close it with a biquill, and then the skin. I hope everything is clear by now. We have a picture of. Okay, we don't have a picture of open coli, but if you understand this part of hepatocystic triangle, you'll be more or less fine. So I think we are done with 5 OTs. We have some more to go. I hope everything is going fine and have some water. Perfect. Okay, someone's there. Okay. So open appendectomy. First bread and butter was lap coli. Second bread and butter is open appendectomy. I'll tell you something. You as interns of Calcutta, Arjikar, if you guys are seeing, you are very lucky. You might be end up doing an independent appendectomy in your internship, which usually at other institutes people would get in their first year or second year. So before we go ahead with the appendix, again, the same approach. Understand the anatomy. We are glorified barbers. We just go in, identify the pathology, cut it, take it out, suture back. Great. So what is the anatomy of the appendix? Okay, great. So we have the tinea coli converging. That is the base of the appendix. Okay, I know this. Appendix is supplied by appendicular artery or the appendiceal artery, which is a branch of the ileocolic. Okay. So this part which has the appendicular artery is known as the mesoappendix. I hope everyone knows this. And then we have 100 positions of appendix, the retrocecal, ileal, post-ileal, pre-ileal, etc. Not go over there. So we have then few incisions. The most important or the one which we use is the McBurney's incision. And how do we mark it? Very simple. We have the McBurney's point, right? We have the umbilicus, the anterior superior iliac spine, spino-umbilical line, 2/3, 1/3. The point is the McBurney's point. You put a perpendicular incision on the McBurney's point. Great, you have the McBurney's incision. Just tilt it a little bit down, it becomes a Langer's incision or the modified McBurney's incision. Why? Because what was seen is this Langer's incision is almost similar to the skin crease. So it is cosmetically better. But then no, there was someone known as Rutherford and Rocky Davis. What they said is, I won't do this. I'll just put an incision just parallel to the body. You understand, right? So this is the Rocky Davis. Just remember, there's a McBurney's and the Langer's incision or the modified McBurney's, and there's a Rutherford Morrison extension. Just remember the few names, you're good to go. Okay, great. So we have a spino-umbilical line, we have the McBurney's point, and we decided to put a line incision perpendicular. Great, we put a incision perpendicular. What was the muscle over here? External oblique, right? Right? External oblique, internal oblique, transversus abdominis, peritoneum, tada, abdomen. Okay. So we cut the external oblique along the muscle, along the line of the incision. Okay. We need to understand here is that external oblique fibers and the internal oblique fibers are running perpendicular to each other. So the moment you cut the fibers of external oblique, you'll see the internal oblique running parallelly. So what you can do is, instead of cutting this, you can just put two Langenbach retractors and retract it, right? Just put two Langenbachs, retract it. After you have retracted, you'll see something known as the transversus abdominis. Okay, great. I'll again go and retract it. Next, we'll see a peritoneum. We'll pick up the peritoneum with two pairs of hemostatic forceps. Remember something we did in the midline laparotomy, where we held the peritoneum with two hemostatic forceps, put a small nick, opened it up. Great. We now identify the tinea. The place where they are coming together is the place where is the appendix. Just close to the appendix or like along the appendix is the mesoappendix. So what was the whole funda? When you're taking out a pathology, you need to ligate its main artery. This is what we did with cystic artery and the gallbladder. This is what we did, we'll do in most of the pathologies. Similar, when we have to take out the appendix, we need to tie the appendiceal artery, or we just tie the mesoappendix. Simple. So we identify the mesoappendix, take Babcock. So here you come, so we have learned two instruments, Langenbach, retract, Babcock, hold. Okay, I held it. We have the mesoappendix. And what we do now is, the ligature is passed around the mesoappendix. So imagine this is the appendix, this is the mesoappendix. We need to ligate this. So I pass a suture around the mesoappendix, ligate it, cut it. So now the artery which was coming parallel to the appendix, supplying the up till the tip of the appendix, has been cut. Pass the suture, ligate, cut. So now the appendix is devoid of any arterial supply. Now we can cut the appendix. How do we cut the appendix? So what it says is the base of the appendix is ligated. Okay. Bursting suture is applied over the cecum around the base of the appendix and kept loose. Okay. So what it says is we need to tie the base of the appendix and also put a purse string suture. So what is a purse string suture? It's like a lady's purse, which has sutures running over here, and the moment you pull the suture, it comes close. It closes on itself, right? It's like a small pouch. So it's known as purse string suture. When you pull the suture, it closes on its own. So why are you doing it? You're doing this to invert the base of the appendix. So we had an appendix popping out. Now we have ligated the appendix, and we are now putting a purse string suture, close it, and the appendix base gets buried. So this is what we are doing. Ligature pass on the 7th grade. Base of the appendix is divided distal to the ligature. Okay. Purse string suture is put. Now see, the purse string suture is tightened and the base of the appendix is pushed inwards. This is what is known as the This is known as the inversion of the stump of the appendix. I hope everything is clear till now. So if you realize, without even reading the steps, we have completed all the steps of appendix. Have we? Let's see. Indication: acute appendicitis, recurrent appendicitis, interval appendectomy. Fine. Mucocele carcinoma. Okay, fine. Anesthesia: usually it is a spinal anesthesia. It can be a general anesthesia or an epidural, depending on how the patient status is. Position is supine. Right. So we have done the indication, anesthesia, position. Steps: preparation and draping, then the incision, or the McBurney's grade iron incision. Okay. Oblique skin incision, 5 to 7 centimeter length, made perpendicular to the right spino-umbilical, passing through the McBurney. We know this, fine. Incision extends through the skin, subcutaneous tissue, fascia of campus and scapa. Remember in inguinal Lichtenstein hernioplasty, we discussed, we first cut the campus, then the scapas. So C, then S. So these are two fascias in the subcutaneous layer. Great. Then we cut the external oblique. Okay, I did. So we understood that the internal oblique is running perpendicular or in a different direction to the external oblique. Okay. So the internal oblique and the transversus abdominis muscles are split. How? Split with a Mayo scissor and retracted with Langenbach's retractor. We know all this, right? Great. What is the next thing? Peritoneum. Okay. So we hold the peritoneum with the hemostatic forceps, put a nick, open it up. So peritoneum, including the fascia transversalis, parietal peritoneum, is inside vertically. Then we enter in the abdomen. Now, how do we identify the appendix is a common question which will be asked if you get this problem card. The convergence of the tinea coli and the location in the right lower quadrant of the abdomen is something which gives an idea, okay, this is an appendix. It is a blind-ended tubular structure, non-motile, right? The appendix is gently manipulated and brought into the surgical field with use of hands. Mesoappendix is divided, base of appendix is divided, appendix is removed, closure is done. Okay, how do we close it? Surgical peritoneum with absorbable sutures, bicryl, great. Muscles are approximated with interrupted sutures. So what do we need to realize is muscles are extremely vascular. So you do a continuous sutures in the fascia because fascia is sort of non-vascular. It's mostly whitish, yellowish. But when you think about muscles, muscles are red. They have a lot of blood supply. So as surgeons, what I said, we just approximate. We don't heal. So we just approximate the muscles and let the body heal with a good supply. External oblique aponeurosis is closed with running sutures. Again, realize external oblique aponeurosis. Aponeurosis is a little less vascular. And then skin is approximate with the interrupted sutures. If we have a female, 20, 23-year female, 16-year female coming in, we usually put in a subcuticular suture because we don't really want the suture scar to be there. Complications can be, we can just skip this part. I think this should be fine. So lap appendectomy is not something which you as undergrads would understand or would know, and you're not expected. But I just wanted to highlight this is because this is the new thing. It's almost same as open appendectomy with the concepts we learned in a lap poly. Same things, create a pneumoperitoneum with a varies, put the trocars in with the camera, identify the structures and ligate, cut, remove, seal back. Great. You understand the advantage. We leave out on the steps of opening the external oblique, internal oblique, peritoneum, splitting. So all that is bypassed. So we just put in trocars, either with a Hassan's open technique or the Verey's needle, 25 mm, 110 mm, go in, we see the mesoappendix, grasp it, then we put a vascular stapler, basically same thing as stapling it up or putting a ligature on the vessel. Then we put a stapler around the appendix, take it out in a plastic bag. You don't want to take it out because you have a fecal. So there'll be high chances of its spillage and leading to infections. You don't want that. Wow, great. So we have done with some good amount of OTs. I think we are left with breast, thyroid, and 3 minor procedures. So I think we are running on time. Great. Breast. The next set of OTs which you learn about is about breast. Again, the same funda. We need to dissect the breast off from the body. And how do we do it? Before we go ahead, we need to understand the basic anatomy. There's a beautiful slide I found. So this is the breast. We have the axillary tail and you have the axillary lymph nodes. Okay? The breast is sitting on the muscle that is the pectoralis major. Beneath the pectoralis major is the pectoralis minor. You have a rectus abdominis. Over here, you have the serratus anterior and the L dorsi. Okay. You have the cephalic vein, the deltoid, and the biceps. Just take 15 seconds to realize this image that, okay, we have a breast. The breast is sitting on the pectoralis major. Beneath the pectoralis major is the pectoralis minor. We have a serratus anterior. We have an L dorsi. We have the biceps, the deltoid, cephalic vein, continuation of the axillary vein. Great. Okay, so let us understand these steps. Be with me. We try to, it might look very complex, but it's very easy. Let's try to dissect it. So you have, okay, perfect. So you have a breast. There is a cancerous lesion from where you have taken the biopsy. And now you need to take this entire chunk out to this incision, which is an elliptical incision. So once you put the elliptical incision, the next structure which you're going to encounter is the fat. So you have two kinds of fat. We have the subcutaneous fat and we have the breast fat. How do we differentiate is not something which you will be asked, but it's stark difference between the two kinds of fat. What we need to do is, once we put the incision, we need to raise an upper flap, raise a lower flap, go in, take the breast out, take it out, suture back the flaps. So first we'll do is, we'll raise a superior skin flap. we go, keep dissecting, keep dissecting, keep dissecting till we reach, okay, just a second. Yeah, this one. So we keep dissecting till we raise the entire superior skin flap. Now, once we have raised the superior skin flap, we need to now take the breast specimen out from the underlining P major. You have to understand that involvement of P major is not the involvement of chest wall. This is one thing which is very common in the TNM classification, and P major is not a component of the chest wall per se, but involvement of serratus anterior is involvement of the chest wall. So pectoralis major involvement is not the involvement of chest wall. Just remember this point. But what we need to do is we need to take the entire breast tissue from the pectoralis major. So what we do is we incise the pectoralis fascia. Along with the fascia, we keep dissecting, keep dissecting, keep dissecting till we take out the entire breast tissue. This is the breast tissue. We have the lateral edge of the pectoralis major. Just forget this. We have some nerves which are there. And you have the L dorsi muscle, right? So you raise a superior skin flap, raise an inferior skin flap, take the breast out in total with the pectoralis fascia. Make sure to preserve some structures, which we'll talk about in the next slide. Make sure to preserve some nerves, which we'll again talk about in the next slide. Once you're done with it, we go ahead with an axillary dissection. So what we basically do is, you remember the axillary tail, this one. So once we are taking this breast out, we keep it attached to the axillary tail because this axillary tail is continuous with the multiple axillary lymph nodes, level 1, 2, and 3. Level 2 lymph nodes are also known as, let's see if you can text in the chat box. Great. We have these steps now. The indication, breast cancer, a very vague term, but you need to realize that locally advanced breast cancers, inflammatory breast cancers, post-neoadjuvant, we go for a MRM. Nowadays, we have a new entity coming in known as the breast conservation surgery. Not new, you must have read about it. The indications of BCS, how we need to go for a radiotherapy after BCS, and small tumors less than 2 centimeters, all we go for BCS, and the role of radiotherapy. Just read about it. But wherever we need to go for an MRM, all the indications which you have in your theory book, this is here. Position supine, with whichever side of breast is being operated, that arm should be extended. So if it's the right, put an arm table, the left arm. Surgical steps. Okay, we read about a transverse elliptical incision. Transverse elliptical incision encircling the nipple and areola, extending 5 centimeter around the mass. So it usually says that if there's a mass, you put an elliptical incision 5 centimeter above and below so that it just encases the entire mass. We raise the skin flap by sharp dissection between the subcutaneous fat and the mammary fat. As I said, there are two kinds of fat. You need to delineate that plane between that subcutaneous fat and the breast tissue fat, and then raise the skin flap. Raising the breast. How do we raise it? Dissect off the uppermost part of the breast along the fascia covering the pectoralis major. Is this what not we read? That we need to raise the entire breast with the pectoralis flap and the pectoralis major fissure. Lift the entire breast of the pectoralis major, preserving the axillary tail in continuity with the axillary lymph nodes. Same thing. हम breast को जब उठाते हैं, we make sure that it is continuous with the axillary tail so that we can do the axillary lymph node dissection. Great. Next step, axillary dissection. We clear the lateral border of the pectoralis major, dissect the level 1, level 2, level 3, and preserve the important nerves. What are the nerves? The long thoracic nerve, which supplies the serratus anterior, the thoracodorsal nerve, or the L dorsi supply, the cephalic vein, and the axillary vein. So if someone can tell me in the chat box, if by any chance we sever or we injure the long thoracic nerve, or if we injure the thoracodorsal nerve, what will be the features? We'll discuss it again, okay? So after we are done with everything, we are done with the raising of the breast, we are done with the axillary dissection, we are done with preservation of the structures, we go for securing of hemostasis. Now, how do we close it? You need to understand that once we are doing such an extensive fat dissection, there's a lot of chance of formation of seroma Also, we are playing with small vessels which are supplying the entirety of breast. We'll be ligating the internal mammary, we'll be ligating the right mammary. So, those might end up bleeding post-operatively. So just to take care about it, we put in drains. We put one end of the drain above the pectoralis major, one below it. This is nothing but the Romovac closed suction drain. You must have seen Romovac drains, like you can press it, it creates a suction, and then it slowly keeps on filling it up, right? So you insert suction drains, then you close the skin incisions with subcuticular or interrupted suture. You can put in staplers, and that's it. You have to remove the skin sutures in 3 to 5 days. We usually go for 7 days. And also we need to make sure that while raising the flaps, they must not be very thin, because if it is very thin, it might end up getting necrosed. You don't want that. Drain catheters are removed when drainage is less than 30 ml per day for 2 consecutive days. Again, duration of tube varies depending on patient to patient. If there is a fluid collection, a seroma, you need to aspirate it. Very important over here is that you need to ask the patient post an MRM to do arm exercises. Why? Because you have already removed the axillary lymph nodes and you don't want lymphedema to be there. Because if there is lymphedema in the hands, it can later lead to something known as a lymphangiosarcoma later, maybe 10 years down the line, and it also troubles the patient. So you don't want the lymphedema to happen, and that is why you want the patient to do an active arm exercise. And you have to basically do a lifelong follow-up, 6 monthly mammo, and then further you need to refer to your theory note for the same. So just recapping it back. So we have a biopsy, we need to give an incision, elliptical incision, we raise the superior skin flap, then we go down, we raise the breast tissue from the pectoralis major along the pectoralis fascia till the lateral edge of the pectoralis major muscle. We preserve the thoracodorsal nerve, we preserve the cephalic nerve and the long thoracic veins. Then we dissect up to the L dorsi. We also preserve the cephalic and the axillary vein. And we then do the axillary dissection, put the 2 suction drains. This is one above, one below. If we have axillary incision, we close it. If we have a elliptical incision, close it. So that completes MRM for you. Okay, so next is thyroid, another endocrine, very important. See, thyroidectomy is a complex surgery which involves very meticulous dissection in terms of vessels and nerves. And these vessels and nerves need to be preserved because their palsies can lead to certain symptoms, which you guys will tell me as we discuss further. And the understanding of the thyroid anatomy is extremely important, because you have very vital structures here, right? You have 2 important nerves. You have the vagus. Basically, you have the external laryngeal, you have the recurrent laryngeal. You have the important veins, the superior thyroid, inferior thyroid. You have the inferior thyroid artery, which also supplies the parathyroid. You don't want to injure any of these, because if you injure the inferior thyroid, you will end up blocking the arterial supply of parathyroid. That will lead to hypocalcemia. It is deadly, I must tell you. If it's managed properly, then it's fine still. If you end up severing the RLN or the SLN, you'll have no vocal cord issues. You'll tell me what happens. And you have the arteries, which if you don't ligate it properly and if you let it bleed, it will lead to hematoma. So before we go further, so yes, we have the Treva-Stewart syndrome, or what happens when there's a long-standing lymphedema. Yes, swinging of scapula will be there if there's an injury, and thoracodorsal loss of contour of back. So what are the indications? So we need to understand that usually the thyroid disorders are also managed by the physicians, where they're given the hypothyroid and the hyperthyroid medications. They also manage Hashimoto's. But usually patients come to us when there is a large goiter, not being able to manage conservatively or by medicines, causing him compressive symptoms. And there are eye signs associated with thyroid. So why we go ahead with the thyroidectomy with eye signs is because these eye signs are due to the antibodies which are being generated against the thyroid. So we remove the source or we remove the thyroid, we can somehow tackle the eye changes which is there. We have the thyroid carcinomas, the anaplastic papillary, follicular. Again, specific indications as to what size needs to be operated with a hemithyroid or a total thyroid. And you have thyroiditis, Hashimoto's if it's causing a lot of trouble, Riedl's if it's causing a lot of trouble, usually managed conservatively. Okay, so before we go ahead, we like to discuss this anatomy. Okay, great. So we have the thyroid. We have two important arteries supplying it: superior thyroid, inferior thyroid, at the internal thyroid. Right? We have three important veins: superior thyroid vein and middle thyroid vein draining the IJV, internal thyroid vein or the inferior thyroid vein breaking into the brachiocephalic vein. So we need to make sure to preserve all these structures. So how are we going to, whatever we do, once we go inside, we'll be ligating the superior thyroid artery close to the pole. We'll be ligating these branches of the internal thyroid artery close to the pole. We'll be making sure to ligate the middle thyroid vein first. I'll tell you why. And then we'll also make sure to preserve the RLN and the external laryngeal. Okay, great. So this picture I've taken from MSR. You have a neck crease incision, the Cocker's incision. And once we give a neck crease, we have the sternocleidomastoid. So this incision extends from one posterior border to another posterior border. Once we give the neck crease incision, we go inside, we encounter two anterior jugular veins. We'll either preserve it if possible or cut if we are not able to preserve it. Then we have the platysma. We cut the skin and the platysma. We have the investing layer of the deep cervical fascia. We cut the deep cervical fascia vertically, pull it up, like pull it out. Then we have this. We also have the strap muscles. We again retract it. The moment we retract, we have the thyroid waiting for us. The first structure which we need to ligate is the middle thyroid vein. After ligating the middle thyroid vein, we go for the superior thyroid and the inferior thyroid vessels. Why the middle thyroid vein is because it is very, it gets plucked off very easily. So if you are manipulating the thyroid, it can just come off and start bleeding profusely. It's very delicate. So it is the first structure which we usually tie. Then we have the branches of the inferior thyroid artery, which is coming behind. And then once we have ligated everything, we have preserved the nerves, we take the thyroid out and suture the deep fascia, approximate the muscles, suture the subcutaneous and the skin. We're done with the thyroid. Let us start the steps. Anesthesia GA. So now the position is the rose position or the barking dog position. You'll not be asked now what is the position, but as final year grads, you'd be asked is how do you create that position? So you have the patient supine with the neck extended by putting a pillow between the shoulder blades. We don't put a pillow beneath the neck, but we put the pillow below the shoulder blade. So the moment you put the pillow below the shoulder blade, the neck automatically extends. Then you rest the head on a sort of a ring, a pillow ring. So supine position with the neck extended by using a pillow beneath the shoulder blades and the head resting on a ring to facilitate exposure of the neck area. Great. Once we are done with this, we have one sternocleidomastoid, second cleidomastoid, posterior border, above joint. Great. 2 centimeter above, Cocker's incision extended from posterior border 1 SCM to posterior border. Now we have done it. Now we need to raise the skin flap. We hook it with skin hooks, pull up, lower flap, skin hooks, pull up, cut the platysma, cut the subcutaneous layer. We encounter the anterior jugular vein. I told you about it. We raise the skin flaps. Next, the deep cervical fascia. Make a straight vertical incision. The investing layer of the deep cervical fascia inside the midline, allowing access to the lying structures. Once you have the fascia cut, you raise the fascia, you see the strap muscles, retract the strap muscles with a Jones retractor if possible. So this is what the investing layer of deep cervical fascia along with the strap muscles are lifted up to expose the lateral lobes covered by the pretracheal fascia. What was the first structure which we divide? Middle thyroid vein. So if it is identified and divided, which is present obviously medially. Next structure, superior and the inferior thyroid veins. Again, ligating them as close as to the upper pole and the lower pole. We preserve the RLN and the external branch of SLN. I would like you guys to write down as to what would happen if we have a bilateral RLN injury or a bilateral SLN injury. Just whatever you know about it, just write it down so we can discuss about it. Then we have the dissection. So we have the thyroid lobes and we have the isthmus. We need to dissect the thyroid isthmus from one end to the other. If we are doing a hemithyroidectomy, then we just dissect at the level of the isthmus. So we take the isthmus with one of the lobes, we keep one of the lobes. Depends on what kind of thyroid we are going to do. Very important to control the bleeding, place the drain if needed, and then close again with layers. Again, the same funda, bicryl. If it's a fascia, then continuous. If it's a muscle, then interrupted. And then we go ahead with the skin closure. So hoarseness of voice is a very superficial term. How I would like you to approach to this question is to understand as to what are the muscles which are supplied by RLN and what are the muscles which are supplied by the SLN. Great. So we'll have aphonia in the right bilateral RLN by Nikita. I would like to know about you. Okay. So complications of total thyroidectomy, very important. किसी ने inferior thyroid artery को काट दिया, parathyroid उड़ गई, hypocalcemia हो गया. Very important to understand the signs of hypocalcemia post OT, where you have the Tozios sign and you need to supplement the calcium over there. You have a hematoma. So now there can be a primary hemorrhage, there can be a secondary hemorrhage, right? So primary hemorrhage usually happens within 24 hours or on the table. Secondary hemorrhage happening after that. But just remember one point: if you are asked if post surgery, post thyroidectomy, there is a hematoma, what are you going to do next? The first step to do over there is take the patient to the OT, because you don't know which vessel is bleeding. You need to open the sutures back so that you can decompress, because that hematoma is going to cause compression on the structures and that patient might end up dying because of compression of the trachea. So you need to understand that if there is an hematoma, you need to drain it. RLN nerve palsy leading to hoarseness and bilateral leading to aphonia and a thyrotoxic storm. So a thyrotoxic storm usually happens when you have not prepared a thyroid patient preoperatively properly. The preoperative preparation of a thyroidectomy patient would involve giving him adequate antithyroid medications if he's a hyperthyroid patient, giving them beta blockers like propranolol, because you don't want to heighten the sympathetic response during the OT, and give him lugosidenine and etc. I'll just share how to prepare a thyroid patient. It's there in ML Saha. You can refer to that. Just because of the class duration, I could not include that here. So I think I'll just see what we are done with. I'll just quickly go through. So we did sutures, blades, and incisions. Lichtenstein hernioplasty, herniotomy, Graham's patch, lap open Foley, open lap appendix, MRM, total thyroid. Now we are left with three important minor procedures. I expect you to read the other minor procedures like abscess drainage and removing of an ingrown toenail. They are very well written in ML or any of the other books, Arthur's book. You just go ahead. But what we now study is so we have the the minor procedures. So before we go ahead with the eversion of Sac, I want you to recapitulate this anatomy which we discussed just a while back. I told you we have an external oblique, we have an internal oblique, and we have the transversus abdominis. The external oblique muscle goes down and folds and forms the inguinal ligament. The external oblique also gives, goes to the scrotum through the spermatic cord, internal oblique as well as the transversus abdominis. So we have the external oblique continuing down as the external spermatic fascia. We have the internal oblique continuing down as the internal spermatic muscle and fascia. And we have the fascia transversalis or the transversus abdominis, which is continuing as the internal spermatic fascia. So this question is often asked in surgical anatomy: what are the layers of the scrotum? From outside to inside, external spermatic fascia, premasteric fascia, internal fascia. From external oblique, premasteric from internal oblique, internal spermatic fascia from the fascia transversalis. Go in, you have something known as the visceral layer and the parietal layer of the tunica vaginalis. Then you further go in, you have the tunica albuginea and tunica vasculis. Great. So this might seem very weird to you right now, but I'll try to simplify it doing a hydrocele and eversion of sac is something as interns you must do. It's something which helps you learn the anatomy better. So this is what a hydrocele is. It is nothing but accumulation of the fluid in the tunica vaginalis and the in between the visceral layer and the parietal layer of the tunica vaginalis. So we need to understand that in order to drain this hydrocele, we need to cut all the layers which are above it, drain out that hydrocele fluid, and do something with the tunica vaginalis so that it does not let fluid accumulate in between the two layers. This is when the surgeons decided that what we can rather do is we can just evert the layers. So if we have like a closed cavity, we open it and we evert it back and then suture it in the back. We don't have that hollow cavity left anteriorly. So this is the basic principle of eversion of sac, which you do in a hydrocele. So what do? We give a vertical incision. So we have the scrotum. We give a vertical incision just lateral to the median raphe, and this is what we open, right? We keep incising. We incide the skin, then the external spermatic fascia, the internal spermatic fascia, the cremasteric fascia, and that is when we see something bulging. That is the hydrocele sac, or we have the tunica vaginalis. Before going there, obviously we have cut and dissected the dartos as well. The moment now we are there inside, what we need to do is we need to create a nick. The moment we do a nick, we have the fluid which is there, which comes out. So we have the aspirator, the trocar, which aspirates all the hydrocele fluid. Then we put the finger in, take a scissors, cut the tunica vaginalis up till the root of this scrotum. See, you have now exposed the cord, you have the testis, you have the sac of the hydrocele, you have cut the tunica vaginalis. Now, once you have cut it, again, you see how you are everting it. You have everted, and in the posterior surface of the testis, you start putting sutures, again the vicryl. Put it inside, make sure there is no bleeders, suture back the dartos, suture back the fascia. And again, try to explain it. You have the hydrocele. Simple. We need to go in skin, external spermatic fascia, dartos, cremasteric fascia, internal spermatic fascia. We go in, we see the bulging tunica vaginalis. We dissect it from all around. Make a nick, get the fluid out, take up scissors, fine scissors, dissect up till the root of the scrotum. Make sure that the spermatic cord in the testis is exposed. Evert it. Once you evert, suture it back, close. Great. SA or LA. Okay, now how do we do it? So it's a daycare procedure. We usually at AIIMS, we would do it in the OPD itself. So you have a 2% lignocaine hydrochloride, which we infiltrate in the spermatic cord and also at the line of incision. Usually it is supine. Then we do the skin incision, incise the layers, cut to the dartos and scrotal fascia, then incise the tunica vaginalis. We separate and incise the vaginalis sac, avoiding testis and cord structure. So we make sure that we don't cut or we injure the testis or the cord structures. Then we evert the tunica vaginalis, suture it back, and then we do a hemostasis. Make sure there is adequate hemostasis, because I'm not ashamed to say right now that my first eversion of sac which I did at AIIMS ended up having an hematoma. So even these complications teach you. The reason why it ended up having an hematoma was because I did not give much attention to the bleeders, and I thought they might settle back. But these small bleeders in the scrotum, they bleed profusely, and it ended up having an hematoma. So I had to open the sutures back, drain out the hematoma, giving some tranexamic acid, and then suture it back. So we close and then we apply a coconut bandage. Coconut bandage is nothing but just a support from below, so that there is less of fluid accumulation due to gravity. Complications being bleeding, infection, and recurrence. Okay, circumcision. A very simple procedure. What we need to understand here is, so I'll just demonstrate. This is the glans, okay, and this is the foreskin which has now engulfed it, right? So we have the glans inside the foreskin. Now, ideally, this foreskin should come down and this glans should be exposed. Now, because it is not being exposed, it gets you a risk of penile cancers. And in religious reasons, like in Muslims and Jews, we do a circumcision. Also, something which interns are infamous for doing is you put in a Foley's, you retract the glans down, put in the Foley's, and you don't, you retract the foreskin down, put in a Foley's, and you don't pull the foreskin back. 3 hours down the intern putting a Foley's, I get a call in the surgery that this patient is having a paraphimosis. That is when I go in like a surgeon and put some needles and drain that fluid and that milk it back below. And if it does not happen, then obviously we have to go for a surgical circumcision. So make sure you don't repeat this mistake. If you're putting a Foley's, you need to pull like if you're pulling the foreskin down, you need to pull it back up. So basically in this circumcision, what we need to do is, okay, great. So we have the penis, we have the foreskin above the glans, and this foreskin is sort of adhered to the glans below. Now we need to break the adhesion between the preputial skin and the glans penis. Once we do it with like a mosquito forceps, we put a dorsal split. The moment we put a dorsal split, we reach up to the corona glandis. We now make a circumlinear incision. See, so we start putting a circumferential cut. You put the circumferential cut and you basically incise this extra skin over the glans. As simple as that. So to incise this, you go in and then put a circumferential incision and it comes out. Simple. So once it is out, you need to now suture back this skin of the penis, penile shaft, with the penis basically. So wherever you have cut that skin, there will be some oozing and some bleeders. You need to tie it with a continuous sutures. Most important to understand here is there is a dorsal frenular artery. So just at the dorsum of the penis, you have a artery which is running. You need to ligate it properly because that is the main source of bleeder. So coming back, religious reasons, phimosis, paraphimosis, usually you give a local anesthesia. So you're often asked as to where would you give that anesthesia? It is given at the base of the penis. Okay, so base of the penis. So you have the penis just at the base of the penis. Where were we giving it for a hydrocellular eversion of sac? At the spermatic cord or the root of the scrotum. Over here, you are giving it at the base of the penis. Then you have the adhesion separation. That is, we grasp the tip of the prepuce with forceps and then separate the adhesion. Then we make a dorsal cut, extend proximally up to 5 mm of the corona glandis, then continue the cut around the penis to the ventral aspect and excise the preputial skin. We make sure to have a good secure hemostasis. We identify the bleeding points and we usually ligate what the book says is a chromic catgut. But you have to understand that a catgut is of animal origin and it is not very inert. So now we are coming up with a vicryl rapide. And vicryl rapides are something as similar as the absorbable vicryl, but which absorbs more rapidly. So it's better. Then we suture the skin edges, which again a theochromic catgut or the vicryl. We apply the dorsal and the ventral midline sutures first. Why? Because we need to make sure to ligate the frenular arteries. And we also apply a figure of 8 at the midline to control the frenular artery and then apply a light dressing. So this is the basis of a circumcision. I hope it's clear. Very simple. You have to remove that excess skin, remove the adhesions, go in, make a vertical slit, then go circumferentially around, take it out, suture the skin, like skin edges, make sure to tie the frenular artery, and you're done. Okay, I think this is the last one for today. Venesection, something which at your college, if you're from Arjikar, at your college, you'll be doing it very often if you see a burns patient in the ER. So how it goes is if you do a dressing of a burns patient, well, you deserve to do a venesection if you're not able to find a vascular access. So usually it is for intravascular access in shock patients, for prolonged IV fluids, for parenteral nutrition, that is TPN, and also for measurement of CVP. So we have various sites of venesections. We have the brachial vein, we have the cephalic vein, we have the great saphenous vein just behind the medial malleolus. So we'll be right now focusing on the basilic vein, which is the usual vein where which is visible on the medial side. So for this basilic vein, what you need to do is very simple. We need to make sure to reach this basilic vein. To reach this basilic vein, we give a skin incision. We keep on dissecting. We remove the skin, the subcutaneous tissue, so that we reach the basilic vein. As simple as that. No great stuff. We pass a hemostat. We pass a forceps below the basilic vein, and we basically dissect it from the other structures around. Okay. We carefully, with a hemostatic forceps, do these types of steps so that the basilic vein is separated from the other structures around it. Then we pass a proximal ligature, we pass a distal ligature. You have to understand that the distal ligature needs to be tied. Why? Because you will now be inserting a vascular access through this vein, and you don't want that fluid which you are giving to go distally to the arm. So you have to put a distal ligature around the vein. You just put a proximal ligature around the vein and keep it untied. What you do next is you take a needle, pass that needle through the tube. So if this is the tube and you have taken the distal axis, you have closed the distal, you have taken a proximal loop. Now this needs to be passed with a needle. So if this is the needle, you need to pass this needle through and through the vessel. So the needle is passed through the middle of the basilic vein. Now, once you pass the needle, you have a part of the vein which is just above the needle. You put a nick on that vessel and you have the access. Okay. It is then you put the cannula inside. You now ligate the proximal ligature so that the cannula remains inside. And now you can again close the skin with the interrupted sutures. Okay. I'll just again recapitulate it. So you basically need to get access to a vein. It can be a basilic vein. It can be a great saphenous vein. Basic idea is to understand the anatomy. Where is the vein? Cut the skin, the subcutaneous tissue, go in, identify the vein, dissect it out, take a distal control, take a proximal control. Distal control is tied. Proximal control is just held up. You pass the needle through and through the vessel. Then incise the vessel just above that needle so that you don't incise it through and through. So that needle prevents you from incising the vessel through and through, because that will not serve our purpose. You just incise it in the anterior surface, take the syringe or the IV cannula, just put it in, and or you can even use something like a nasogastric tube, which is 6 French or 8 French, the thinner ones. You put it in, then tie the proximal ligature, suture the skin back, and you're done. I think this would be the steps: great saphenous vein, basilic vein, cephalic vein, and the deltopectoral groove. Antiseptic cleaning, obviously, you do under local anesthesia, 2% lignocaine. We give a small incision. We dissect the vein. We put 2 ligatures. We do a venotomy. Venotomy is nothing but otomy. Otomy is making a cut. Like otomy is opening. Ectomy is removal. Cannula insertion, then connect to the IV fluid, and then close, and then do the dressing. I think that's done for today. We'll just have a quick recapitulation of all these slides. If anyone wants me to repeat any of the operatives, please, it's now the time that you can start texting on the WhatsApp chat, or on the Zoom chat. Please. I'll wait. I think there might be a lag. You can do that as well. Okay. Nikita wants me to repeat Graham's patch. Anyone else wants me to repeat anything? Okay. So I'll just quickly recapitulate. So we have the sutures, blades, and incisions. We have the sutures. I'll share the PDF with you. We have the different abdominal incisions. We have the Lichtenstein Hernioplasty. Important to remember the various layers which we have cut in, how we took care about the mesh. Then we have the Herniotomy, something very simple, not going to repeat. We have a midline laparotomy as to how do we access the abdomen. We have a modified Graham's patch. So over here, just Nikita, what you need to remember is, after doing a laparotomy, we have a perforation, and that perforation we need to close. So to close that perforation, we need nothing but 3 good vicryl sutures, 3 or 4 vicryl sutures, pass from one end of the perforation to the other, make a suture, like close it, then put the omental patch, then take back the suture and tie the omental patch. This is as simple as that. The rest of the step is as similar as to how we do a midline laparotomy. Then we have the cholecystectomy. Here you need to remember the cholecysto triangles and the hepatocystic triangle. Then lap chole, just the port positions are very important. For open chole, just need to remember the dissections and the anatomy. Open appendectomy, anatomy of the appendix, how you go ahead, how are the structures cut or retracted. Then you have breast anatomy is important. What are the structures or the nerves which are preserved? What are the structures which are severed? Then the thyroid anatomy is important. You go ahead with the layers of the scrotum. If you know this, eversion of sac becomes easy. Then you have circumcision and venesection. So I think this is done from my end. I hope it was a fruitful session for everyone. If you have any doubts, you can mail at drpanani@gmail.com. You can ping me on my Instagram. I took the references from Zollinger's, which is our Bible for Atlas of Surgical Operations. I refer to Bailey and Bedside Clinic. So I think this will be done for today. I hope it was a fruitful session for you. I'll try to share the recording if possible. I'll upload it on YouTube. If you have any more doubts, please feel free to text on the WhatsApp group. I'm eagerly waiting for your feedback on this session. This was my first time taking it. So I hope it proves to be useful for everyone. Thank you. If you have any doubts, if you have any suggestions, please go ahead. I think I'll summarize. Thank you so much.